Take your time. You can go up to 40 minutes and then we'll have a time for question and answers.
Yeah, I only put about 35 slides together thinking that
Yeah,
you guys would
yeah,
want to have some time
yeah.
for questions at the end. So I'm just going to go ahead and share my screen and get started if that's okay.
Yeah, Professor Anofo for the opening remarks.
Yeah. Good afternoon, good evening, good morning. Welcome to this meeting once more with IVU Med in our session with PAUSA. And today we're talking about muscle invasive bladder cancer. And our guest speaker is Phillip Abbosh. I think it's going to be a very interesting thing. So we all listen as you come on board. Phillip Abbosh, you're welcome.
Thank you for introducing me.
You can share your screen now.
Okay.
Yeah.
Okay, everybody can see okay? Okay, I'll just start by asking it, everybody can hear me okay? Is there any
Yeah, that works.
Yeah. Okay, so I put this talk, you guys, if you're interested, you're welcome to download it. There's nothing, proprietary about this talk. If you just take a picture of the QR code here, and it'll come up at the end if you guys want to download it later. So this will take you to a link that you can download my entire talk to. Okay, so I'll just start by acknowledging my conflicts of interest. I have research support with a company called Natera, where we work on kidney cancer biomarkers, and then Merck and Janssen are some of the companies we work with on our bladder cancer projects. I also have a consulting role with Artara Therapeutics, working on an intravesical agent. So I just want to acknowledge that up front. I'll tell you guys a little bit about myself. I did my training at a program in St. Louis called Washington University. I was a fellow here at Fox Chase Cancer Center in Philadelphia, where I still work. I currently am a urologist at a hospital called Albert Einstein Medical Center. And then I actually have a lab where we do basic and translational work in bladder and kidney cancer at Fox Chase, which is kind of just down the street. My research interests include bladder cancer biomarkers, mouse models, and intravesical therapeutics that we're developing. And I also have an interest in international medicine. I work with a group called Project Haiti, and went on a visit there about 2 years ago. But since then, we haven't been able to get back because of some of the political unrest that's been going on there. I will give you guys some objectives for the talk. Hopefully at the end of the talk, you guys will be able to understand the natural, not that you don't already, but I'll review the natural history and proper diagnosis and staging of patients with muscle invasive bladder cancer. I'll go through some of the surgical and non-surgical treatments of bladder cancer, and then I'll talk a little bit about some of the emerging therapeutics and diagnostic tests. I'll start with just an index case, which is a 67-year-old man who presents with hematuria, and you scope him in the office, and he's found to have a large sessile bladder tumor, and we get a cytology from the office, and it shows that there's high-grade urothelial carcinoma. And I'll just take a minute here to sort of go through some of the different growth patterns, both papillary and sessile, for bladder cancer. So typically with papillary tumors, you don't see CIS as commonly. It's very common with sessile tumors. The T staging, the local tumor staging, papillary tumors tend to be, you see a lot of non-muscle invasive tumors that are papillary. The sessile tumors tend to be more of the muscle invasive phenotypes. The papillary tumors.
Yeah, the skin again, please.
I'm sorry?
This skin sharing.
Screen sharing? Am I not screen sharing? It says I'm screen sharing.
Yeah, it stopped a second ago.
Is that better? Can you guys see now or no?
Yeah, it's okay. The screen sharing is okay.
Okay, I'm going to keep going. So papillary tumors, I think, have a lower risk of progression versus sessile tumors, which tend to have already tend to present with muscle invasive disease. The expression subtype, which is something I'll talk a little bit about later, the papillary tumors tend to have a luminal expression subtype, which is actually very similar to breast cancer, to luminal breast cancers. And then the sessile tumors have a basal expression subtype, which is also very similar to a basal breast cancer. Genetically, these tumors are very distinct as well. In papillary tumors, you tend to see a lot of a receptor tyrosine kinase called fibroblast growth factor receptor number 3, which it tends to be mutated, hyperactivated by mutation, as opposed to sessile tumors, which tend to have loss of tumor suppressors, p53, and other cell cycle tumor suppressors. Okay, so the patient, you take the patient to the operating room to do a TURBT. He has a very large tumor. It takes about 2 hours. And even after 2 hours, it was incompletely resected. The pathologists look at his tissue and note that there's high-grade T1 with lymphovascular invasion, but note that there's no muscle in the specimen, which is important. And I'll kind of talk about why now. So this was a study, and I'll try to, when I'm discussing studies, I've tried to put a link with a bibliographic reference to the study at the bottom of each slide where I'm talking about a study, if you guys want to look these up later. These tend to be what are called DOI, or digital object identifiers. If you put this 10 web address in your web browser, it will take you to the paper. Okay, so this was a study looking at almost 2,000 patients who had who were diagnosed with non-muscle invasive bladder cancer, and we're looking at the pathology reports of all 1,900 of these patients. And in about 50% of the pathology reports, the pathologist noted that there was muscle present. In 30% of the patients' pathology reports, the pathologist noted that there was muscle absent. And then in about 20% of the cases, the muscle presence or absence was not mentioned. And what these authors showed was that presence of muscularis propria, and specifically mention of muscularis propria, was strongly linked to survival. And here's what that looked like. So if you look at the proportion of patients that died from bladder cancer, and you compare the muscle not mentioned versus muscle present versus muscle absent, you see that there's a very strong correlation with death. So if the pathologist doesn't mention whether muscle was involved or not, the risk of dying from bladder cancer is greatly increased versus if there's muscle present or absent. So it's incumbent on both the urologist and the pathologist to communicate. So for instance, if I ever get a pathology report that doesn't mention whether muscle is present or absent, I will always go back to the pathologist and ask if they can clarify if I sampled muscle and there wasn't tumor in the muscle versus I just completely missed muscle altogether. Because I think it's an important distinguisher and to assign the right therapy for the patient, and it's also obviously now a strong predictor of outcome. So my punchline here is that the quality of the TUR is very important for patient outcome. I'll talk a little bit about the epidemiology of bladder cancer now. So bladder cancer is the 10th most common cancer worldwide. It's the 6th most common in men. There's a gender bias, which you guys all know. It's about 4 times more common in men than in women. At presentation, most patients tend to be non-muscle invasive, although a fraction of these will progress. About 20% will have localized muscle invasive bladder cancer, and about 5% will present with metastatic bladder cancer. There are some risk factors. Tobacco, of course, is the most well-known risk factor. It's a carcinogen. Aniline dyes, which are sometimes used in hair dyes and in newspapers, are also exposure to aniline dyes as a risk factor. And then also arsenic, which can actually be found in some in groundwater in some locations. And then also, of course, very relevant to Africa would be schistosomiasis, which is a bacteria which can implant itself into the bladder wall, cause a lot of inflammation, and then cause bladder cancer. So back to our patient, he underwent a second TURBT and now a CT urogram. And what you can see on the urogram is that there's a deformation of the bladder wall, suggesting that there may be some extravesical disease. So when we re-TUR the patient, now we see that there's muscle that's sampled and there's tumor in the muscle. It's a muscle invasive bladder cancer. We also note that there's a lymphovascular invasion in the pathological specimen. The CT urogram, as I mentioned, showed this suggestion of extravesical disease, but there's no abnormal lymph nodes in the pelvis or retroperitoneum, and there's no upper tract filling defects. So now I'll talk a little bit about clinical staging versus pathological staging. So clinically, we would say this patient has clinical T3 bladder cancer because of their CT scan. And about 40 to 50% of patients that are clinically T2 will actually be upstaged at the time of radical cystectomy. And I'll talk about some of the data behind that now. So the known risk factors to have a patient get upstaged from T2 to T3 or T4 are lymphovascular invasion, hydronephrosis, an abnormal exam, i.e. pelvic fixation or prostatic fixation, and then in some literature, variant histology is also a risk factor for upstaging. So if you look at in large retrospective studies, looking at patients that have none of these risk factors versus patients that have at least one of these risk factors, what you'll see is that in the absence of risk factors, about 60% of patients at the time of cystectomy will have a T2 bladder cancer, and this is absent any chemotherapy, versus if they have any of these risk factors, about 40%, only about 40% will have bladder localized disease. So these are important risk factors in trying to determine who should or should not receive neoadjuvant chemotherapy, which I'll talk about here in a minute. If you look at these risk factors from a survival standpoint, again, you see that high risk patients with any of these risk factors, which would be considered high risk, are at a much higher risk of death from bladder cancer after their cystectomy than patients with none of these risk factors. So our patient has two risk factors, both the lymphovascular invasion and the hydronephrosis. So this could be used as a rationale to give patients neoadjuvant chemotherapy. And when giving neoadjuvant chemotherapy, there are two sort of general schools of thought. So there's the Houston model, which is mostly supported by data out of the MD Anderson Cancer Center, which is to only give neoadjuvant chemotherapy to patients who are high risk, who have one of those risk factors I just mentioned, that is an abnormal exam, lymphovascular invasion, hydronephrosis, or a histological variant, which minimizes the chemotoxicity because you're only treating patients that have risk factors, and you're treating patients who are most at risk for being upstaged. The other model, which I think is followed by almost all other institutions in the United States, is to give chemotherapy for everybody rather than just those who are high risk, which does maximize chemotoxicity, but also is associated with an increased survival benefit and a much higher complete response rate at the time of cystectomy. And I'll kind of go through that data now. So this is actually my favorite randomized controlled trial in all of GU oncology. This was the Grossman et al. Randomized controlled trial, which was published in 2003 in the New England Journal of Medicine. In this study, the authors found 317 patients and randomized them to receive either radical cystectomy alone or preoperative MVAC, which is methotrexate, vinblastine, doxorubicin, and cisplatin, followed by radical cystectomy. I will also note that all patients in this trial were referred to the trial institution, and so they were diagnosed at a prior hospital and then referred. So they had a second TUR. So all patients had two TURs and then were randomized to either receiving chemotherapy or just undergoing immediate cystectomy. And what you see in the survival curves is that the patients that achieved a complete response, in other words, at the time of their cystectomy, there was no disease left in their bladder, regardless of whether they got chemotherapy or not, had a very high survival compared to patients who had residual disease in their bladder. Again, regardless of whether they got chemotherapy or not, they had a lower response. And so what this leads us to believe is that the patients that have a T0 bladder, regardless of how they got there, are going to be the ones that have the highest survival from their bladder cancer. So in other words, the survival is largely driven by the T stage at the time of cystectomy, and that is to distinguish residual disease versus no residual disease. Again, the chemotherapy arm of the trial had a almost 40% complete response rate, as opposed to the arm that got 2 TURBTs and then cystectomy. And what you see is that the chemotherapy administration increased the likelihood of downstaging to a complete response by almost twofold. Okay, I'll also just kick in some of my own thoughts on neoadjuvant chemotherapy. Cisplatin is kind of the key agent to neoadjuvant. Carboplatin is thought to be ineffective, and there are trials to support that statement. I mentioned that trial. I mentioned the Grossman trial was in 2003. Since then, most institutions have moved to using a dose-dense regimen. Our institution happens to be an MVAC house. There are other institutions that tend to use gemcitabine. The reason to use dose-dense protocols is because they're faster. But in order to give them, you need to have modern antiemetics, because these things can be do induce a lot of nausea and vomiting, and you have to have growth factor support. So if you're giving people chemotherapy in a very rapid succession, cycle after cycle, they tend to have bone marrow suppression unless you give growth factors. But in my experience here at Fox Chase and at Albert Einstein, dose-dense MVAC tends to be very well tolerated. So as I mentioned, we use dose-dense MVAC at my institution, but other institutions tend to use gemcitabine and cisplatin. I'll go through some of the differences about why, and specifically highlight why we tend to use MVAC versus other institutions that use a lot of gem-cis. So with dose-dense MVAC, most institutions will give 3 cycles. With dose-dense gem-cis, many institutions give 3 cycles, but for instance, like Memorial Sloan Kettering, which is a very strong proponent of gem-cis, tends to give 6 cycles. There's consistently a 35 to 40% complete response rate with MVAC. That response rate is a little bit lower with gem-cis, although both have a downstaging to less than or equal to T1 of about 50%. There is some data that suggests that if a patient is downstage to T1, rather than when they had a known muscle invasive bladder cancer, that also is associated with a very high survival advantage, almost equivalent to having been downstage to being T0 at the time of cystectomy. The time to cystectomy in both groups, if you're giving 3 cycles, is about 9 to 10 weeks. Where they differ, I think, is in the toxicity. So these publications, this JCO paper and the European Urological Oncology, European Urology Oncology Journal. These are both prospective trials from our institution. And what we found was that with MVAC, there was only a 15% grade 3 to 4 toxicity, but with gem-cis, it was much higher at 35%. They both tend to be marrow suppressive and renal toxic, of course, from the cisplatin. Where they differ specifically was with gem-cis, which actually had in our hands about 20% vascular toxicity. And by vascular toxicity, what I mean is there were several patients that had MIs, strokes, and venous thromboembolic events, to the point where the trial was actually stopped early. We had planned to recruit, I think, 44 patients. And on this trial, we stopped the recruitment after 31 because of all the vascular toxicity we were seeing. It led to some, obviously bleeding issues at the time of cystectomy when you're doing surgery on patients that have like a DVT history, which they got from their chemotherapy. I will also mention that gemcitabine itself is probably the agent that causes a lot of this vascular toxicity. If you look in the lung cancer and pancreatic cancer literature, where they use gemcitabine a lot in metastatic patients, you tend to see a lot of VTE events in patients who are receiving gemcitabine. Okay, so I will also mention that the post-op complications is higher in the gemcitabine group as well, with about 43% of patients having a grade 3 complication after surgery versus only 19% in the dose-dense dose-dense MVAC arms. So the point here is that our institution tends to be an MVAC institution, although many institutions in America and outside of America use GemCis as well. Okay, I'll talk a little bit about the science of chemo response now. So bladder cancer, just like any other cancer, is caused by an accumulation of somatic mutations. In bladder cancer specifically, some of these mutations occur in DNA damage repair genes, which has now been shown to be a genetic susceptibility to chemo response. So because chemotherapy is a DNA damaging agent, and some tumors carry deleterious mutations in DNA damage response pathways, you can treat those tumors that have mutations in these genes with DNA damaging agents, and it's shown to be very highly toxic to the tumors, which causes a complete response. So here are a list of some of the mutations that are known to occur in bladder cancer. So ERCC2 is sort of the one that people have most strongly shown is associated with chemo response. There's also genes in the mismatch repair pathway and the double-stranded break pathway. These tend to be pretty common. So each of these little gray boxes is one single patient who underwent sequencing of their tumor. If there's a green box, that means that there is an alteration. If there is a black box, that means that not only was there a genetic alteration, but that the alteration was known to be deleterious because it resulted in truncation of the gene. And I see some of you guys taking pictures. Again, if you guys want to download the entire talk, you'll have access to the entire talk. I'll put up a QR code at the end of the talk as well. This ERCC2 gene that I mentioned is the one that's most strongly associated with chemo response. So the circle here, this is from a study where 50 patients with muscle-invasive bladder cancer who underwent chemotherapy underwent whole exome sequencing of their tumor. The size of the circle represents the proportion of patients who had an alteration in this gene. And what you see is that ERCC2 was the only gene that was associated with response, and that's shown a little more clearly here. So if you look at all the responders and all the non-responders, what you see is that ERCC2 is mutated only in responders and in none of the non-responders, as opposed to other genes where the distribution of the mutations was evenly distributed between both groups. If you look at these mutations in a cell line model of bladder cancer, what you see is that in cells where ERCC2 is wild type, the cells, if you treat them with platinum, they have a very high survival rate, versus if you mutate the ERCC gene, there's a much lower survival of these cells as you treat them with platinum in a petri dish. And so this shows that not only was ERCC2 mutation enriched in responders, but also that the same mutations that were found in these patients cause the death of the cell when treated with platinum. So very strong evidence that ERCC2, which is a known DNA damage repair gene, is going to be associated and is in fact predictive of chemo response. So cystectomy, now that we're talking about cystectomy, I'll just kind of give some of the background. It tends to be a very expensive procedure. Bladder cancer is the most expensive cancer to treat. It's also very complicated. Readmission rates are essentially the same as if patients are undergoing a Whipple, pancreaticoduodenectomy, esophagus removal, or a pneumonectomy. There's about a 30% grade 3 complication in most radical cystectomy series, with a 2 to 7% perioperative mortality rate. And it's life-altering. Patients have to have permanent urinary diversion, often with an ileal conduit or a neobladder or some other kind of continent cutaneous diversion. So, it's a very morbid procedure. And most of the morbidity, I think, is related to the diversion. So, at least in America, most patients will undergo an ileal conduit urinary diversion, with about 20% of patients having some kind of a continent diversion. These complications are, tend to be infectious, GI, ileus, anastomotic leaks, et cetera. And then there are some electrolyte abnormalities that are associated with an ileal conduit or a neobladder, because there's urine now in contact with an absorptive epithelium, such as that which is found inside the ileum. There are other complications that are related to surgery more generally, such as vascular thromboembolic events, anemia, transfusions, issues with the conduit, ureteral strictures, et cetera. So I'll take it back to our index patient here. He gets 3 cycles of chemotherapy and sails through chemo, no hangups. And now, after you start to counsel him about cystectomy, and you tell him how complicated it is, et cetera, and he starts to waver, and he says, well, doctor, can you biopsy my bladder after chemotherapy and then decide if I need to have cystectomy? In other words, if I still have bladder cancer, then sure, you can take my bladder out. But if I had a complete response, I don't want to have my bladder taken out. And you see this often because patients are very attached to their bladders. So the question this patient essentially is asking is, can neoadjuvant chemotherapy alone cure bladder cancer? And so this has been looked at. So if you take, and this has been looked at both retrospectively and now prospectively. So if you take muscle invasive bladder cancer patients who are treated with chemotherapy alone, and then do a biopsy or a TURBT and scans after their neoadjuvant chemotherapy, and if you say, I don't identify tumor with the scan or the biopsy or the TURBT, and then the patient undergoes, defers cystectomy, you can kind of look at what the outcomes are. And there are several studies that have looked at this, and these are just some of them. But essentially what you see is that if you give neoadjuvant chemotherapy or just do TURBT alone, and then take the patients that had clinical complete response, and this is how many patients in each of these studies there were that had a clinical complete response, the failure rate, no matter what your metric is, whether that's recurrence within the bladder, cystectomy, metastases, et cetera, what you see is that the rate of recurrence in patients who you deem to have had a clinical complete response is somewhere around 30%, maybe up to 50%. So essentially what this shows is that clinical staging after chemotherapy is not very good. About 30 to 50% of the patients that you deem to have had a clinical complete response will fail, cystectomy avoidance, essentially. So the point here is that clinical complete response is not equivalent to pathological complete response. So, and these were done at very, prestigious, academic medical centers. So it's not, the problem isn't that we had people who didn't know what they were doing. These were experienced people who take care of bladder cancer on a daily basis. So I'll just mention a trial we have here, which is a prospective trial where we've treated about 61, these are 61 patients who are already undergoing radical cystectomy. and about 38 of them had neoadjuvant chemo. The point of the trial here was to undergo a bladder biopsy at the same time as cystectomy. So under the same anesthetic, the urologist put the patient to sleep and then put a cystoscope into the bladder and did a biopsy or a TURBT of their bladder, and then did a radical cystectomy. And what this does is it removes any of the potential selection bias of patients who say have a biopsy and then say they don't want to have a cystectomy. So all these patients had a cystectomy. And what we showed is that if you biopsy these patients and determine that they had a clinical complete response, about half of the patients actually had a complete response. The other half either have non-muscle invasive bladder or in some cases, muscle invasive bladder cancer. If you biopsy these patients and find that they have non-muscle invasive residual disease, at the time of their cystectomy, most of them actually have muscle invasive disease. Some of them have non-muscle invasive disease. Very few have achieved the complete response. So the point here again is that this idea that you can biopsy someone after chemotherapy and say with any kind of confidence whether they had complete response or not is just totally wrong, at least in our experience and in the experience of many other urologists. And the point here again is that half of the patients that are presumed to have had a clinical complete response actually have residual disease, with about 25% of the patients actually have residual muscle invasive disease. This sort of brings, I'll just mention some of the work we're doing in our lab, and that is to use urine as a potential biomarker of residual disease. So the idea here is that tumors shed their DNA into the urine, and we can collect this urine from these patients and then do sequencing to identify the mutations that are shed from the tumor into the urine, and those are detectable. So the idea is that if you can detect a mutation after chemotherapy, then it's very likely that the patient has residual bladder cancer. But if you're unable to detect a mutation after chemotherapy, then it's very likely that the patient has no residual disease. And we've actually shown that this is a very strong correlate of residual disease in patients after they have chemotherapy and have cystectomy. So if a patient has cystectomy, we know what their residual disease status was, and then we can correlate our urine test to what the pathology of the cystectomy specimen was. The idea is that eventually we might be able to use urine as a biomarker to tell patients whether or not they actually need to have radical cystectomy or not. Okay, so let me take it back to our 67-year-old patient. He undergoes a TURBT after his chemotherapy. So we proved to the patient that there is actually, in fact, residual muscle invasive bladder cancer. So even though he has residual disease, now he says, I still really don't want to undergo radical cystectomy. So what other options are there? Trimodal therapy would be this guy's best option. So trimodal therapy means patients undergo endoscopic resection. Usually they get neoadjuvant chemotherapy, such as what we gave him already with the dose-dense MVAC, and then they would undergo radiation to the pelvis. And then this should say ideally concurrent with chemotherapy, not radiation. I apologize for the typographical error. There are several randomized phase 3 trials to support this approach. Patient selection, though, is key. Ideally, patients who undergo trimodal therapy have only one site of disease. It's better if they don't have CIS. It's better if they don't have hydronephrosis. It's better if they have no non-urothelial histologies, although there's mixed data about that. And especially if patients have had prior pelvic or no prior pelvic radiation. So let's say someone has had pelvic radiation for, say, prostate cancer. They probably would not be a good trimodal therapy patient because they would accumulate toxicity from all the radiation to their pelvis. We often give trimodal therapy to patients who are elderly or heavily comorbid. Pardon me. Often the choice of chemotherapy is important here. So our institution tends to use a lot of cisplatin or 5-FU or cisplatin paclitaxel or cisplatin alone. Although, as I mentioned, these patients tend to be older, they tend to have a lot of comorbidities. So if you can't use cisplatin, 5-FU and mitomycin is a really good alternative. And again, there are phase 3 trials to support all of these. It's less preferred from an oncologic standpoint if you're giving single agents such as gemcitabine, 5-FU, or paclitaxel, or capecitabine, which is an oral version of 5-FU. These are less preferred because they don't have as good of an oncologic outcome, but they do tend to be better tolerated in patients who are elderly and comorbid. Some notes on radiation. It's often given as 1.8 to 2 gray fractions, up to a total of 40 gray if you're just treating the bladder. Radiation oncologists will give up to 50 gray if you're treating bladder plus nodes, or all the way up to 66 gray if you're treating bladder plus a boost to the tumor. There is hypofractionation, which means that instead of giving smaller doses of radiation, you would actually give larger doses. But if you're going to hypofractionate, you can't give chemotherapy at the same time because it'll be too toxic. What this does is it reduces the number of trips that the patient needs to make to the radiation oncologist's office without significantly increasing the toxicity as far as we know. Radiotherapy alone can be palliative. So it's really good for patients who have hematuria. Say if you have a patient with a large bladder tumor who has metastatic bladder cancer, and you're obviously not going to do a cystectomy in the setting of metastasis, you can do radiation because it's very good to treat hematuria, to keep patients from needing to have transfusions and catheters, et cetera. Our default at Fox Chase Cancer Center is to try to give neoadjuvant dose-dense MVAC followed by radiation plus these radiosensitizers, 5-FU and mitomycin. But again, the choice of chemotherapy, which you give concurrent with the radiation, is not always the same depending on comorbidities of the patient. So you can ask the question, how effective is chemoradiation? And what I'll talk about here is a meta-analysis of 6 prospective RTOG trials, which is an oncology cooperative group, which focuses on radiotherapy. In all, there were 468 patients. They all received some form of chemotherapy plus radiation. Overall, their survival at 5 and 10 years was 57 and 36%, with 71 and 65% 10-year survival. The bladder cancer specific mortality was pretty low, only 24% at 5 years. And then you see the data for local and muscle invasive local failure, as well as distant metastases. So even at 5 and 10 years, you're having up to a third of patients who develop metastases with concurrent chemo radiation. I will also note that clinical complete response, again, which is not necessarily pathological complete response, but it was documented in almost 70% of patients that underwent chemoradiation. If you achieved a clinical complete response in these cohorts, your survival, disease-free survival, and metastasis rate were all better than patients who had clinical residual disease at the end of chemoradiation. Complications from radiation, often patients will have urinary tract symptoms while they're getting radiation. They often will have erectile dysfunction while they're getting radiation as well. Those tend to sort of get better when the radiation stops, although they can persist and do typically get worse with time. Hematuria will happen in patients who have had radiation. Patients are sometimes surprised when I tell them that it's radiation that's causing their hematuria, even though they had radiation, say, 5 or 10 years ago. The hematuria can occur anytime after the patient has been radiated. There is also a higher risk of second pelvic malignancies after radiation. And this is data I borrowed from the prostate cancer literature. So if patients have prostate cancer and then get radiated, they have around a 2-time higher risk of between 2 and 5 times higher risk of having a pelvic malignancy at 5 and 10 years after radiation. The same thing is found in patients who have endometrial cancer. So women that get radiated for their endometrial cancer have a higher risk of bladder and colorectal cancers. These cancers tend to be found in the bladder, There are sometimes lymphoproliferative diseases such as leukemia, lymphoma, and sarcomas, etc. The risk of a second malignancy is lower with 3D conformal and image modulated radiotherapy as opposed to 2D radiotherapy. I don't really have a lot to say about cystectomy. This surgery is essentially the same as it's been for about 40 years. There was a trial that was published recently looking at robotic surgery versus open cystectomy. They recruited 300 patients and this was randomized. The survival and complications were about the same in both groups, although there is some fear over peritoneal carcinomatosis of the peritoneum in the robotics group. This has been confirmed in some retrospective studies, although the mechanism of why patients get carcinomatosis is still not really clear. I will say that although cystectomy is essentially the same as it's been, some of the things we do to patients after a cystectomy are different now. So our institution uses what's called early recovery after surgery, after abdominal surgery specifically, which was sort of developed in the general surgery literature. I'll go through some of the components here. If you use these kinds of ERAS protocols, you do not give patients bowel preps. There's carbo loading prior to the surgery, which helps with their nutritional status after surgery when they're NPO. During the surgery, the anesthesiologist will use real-time cardiac output measurements to adapt how they resuscitate patients. It used to be, say, when I was a resident, patients came out of the operating room completely flooded with fluids, and we were always giving them Lasix post-op and then chasing their blood pressure, et cetera, because of the blood loss. And so when you titrate the resuscitation to the cardiac output, you end up giving a lot less fluids to keep patients' blood pressure steady, and you tend to use more blood rather than crystalloid. There's also protocols to use epidurals and multimodal pain management rather than just giving patient narcotics. Narcotics, of course, slow down the bowels and cause ileus. And then with ERAS protocols, we start giving patients nutritional supplements on postoperative day 1. There's also evidence that if you give patients chewing gum, that reduces their risk of ileus and decreases their time to receiving a regular diet and their time to flatus. These protocols, as I mentioned, speed up the recovery of bowel function. And then that results in a faster discharge of patients. And importantly, there's probably a lower readmission rate and maybe a lower complication rate in using these ERAS protocols. So there's a lot of upside with very little downside to using ERAS protocols. Quality of life considerations in patients who are undergoing cystectomy and urinary diversion. You can measure quality of life using what's called the FACT cystectomy index, or functional assessment of cancer therapy. This questionnaire is an index which measures the physical, social, emotional, functional, and overall domains in patients who are undergoing radical cystectomy. It's validated and it's internally consistent. This is an example of what is on the FACT questionnaire, asking about weight loss, urinary conditions, questions about social activity, physical activity, sexual activity, etc. This was looked at prospectively in 73 patients who underwent cystectomy. The authors of this study measured the health-related quality of life before surgery and 6 months post-op. They found that the only domain that was different pre-op to post-op was the emotional, and it was actually improved, curiously, in the post-op patients. And the authors suspected that this may be because of anxiety about having bladder cancer, which was relieved after having their treatments. Regarding the urinary diversion, whether they had a continent diversion or an incontinent diversion, like a conduit, made no difference in their health-related quality of life. And I think this is important because I often will counsel patients, when they're trying to choose which kind of urinary diversion they're going to have. The conduit, of course, is obviously much more straightforward. But the downside is that the patient has has their urine empty into a conduit and into an ostomy appliance. And so there are some patients who have really important body images, as opposed to patients who sort of just want to have a continent diversion, which can be associated with complications, readmissions, et cetera, as well as complications that lead to incontinence, which may cause a lot of health-related quality of life issues down the road as well. Okay, there is definitely a cystectomy volume outcome relationship. As I mentioned, it is a very complicated surgery. There's high complication rates even in experienced centers. Some of this volume outcome relationship is probably related to the ability of a surgeon or a hospital system to rescue the patient with a complication. So that means both early recognition of complications, as well as having the resources to fix or correct the complication. So that means having ICU with well-trained nursing staff, interventional radiologists, medical specialists, and other services such as like other types of surgeons, et cetera. Many centers in America don't have some of these resources, and when they're doing cystectomy at these smaller volume hospitals, in the absence of these resources, it leads to not only complications, but the inability to rescue the complication. And so there are worsened outcomes when cystectomy is done at small volume hospitals. That's something to keep in mind as you're doing cystectomy in other parts of the world where there may not be high volumes in some places. Patients need access to care, but sometimes that care, especially for cystectomy, might be better delivered in a concentrated manner. This, of course, has to be balanced with patients' needs to travel. So not all patients can travel to go to, say, a center of excellence to have a cystectomy. So there are potentially ways to mitigate some of those issues, but in all honesty, it's very difficult to mitigate some of those circumstances. This is where I think having telehealth is very helpful. Internet, Zoom calls, et cetera. If you're able to coordinate with a center of care and ask questions and have people follow along and help out, it may make cystectomy safer at a small volume institution. Take-home messages from my talk. It's really important to make the right diagnosis. I mentioned early on when doing your TOR to collect muscle in the specimen. I personally try to give neoadjuvant chemotherapy to all of my bladder cancer patients. I talked a little bit about cystectomy avoidance after chemotherapy. I think it's really a gamble for patients. Cystectomy is complicated, but the early recovery after abdominal surgery protocols can help quite a bit. Trimodal therapy is a good alternative to patients who don't want to have cystectomy or are not cystectomy candidates. And then I mentioned cystectomy, regionalization of care and having centers of excellence. But I also mentioned that this is a double-edged sword because in some ways it may limit patients' access to having cystectomy and actually result in reduced care for those who have to travel and cannot. Again, if you guys want to download this talk, you can just take, and I'll leave this picture up here for a while. If you guys want to just take a picture of this QR code, it'll take you to a link where you can download all of this talk in its entirety. I have my contact information here. If you guys want to email me, call me, text me, etc., I'm happy to take questions with communication of your choice. Okay, with that, I'm going to take some of the questions. There was you can use the chat option or unmute yourself, I guess, if you want. First question here is from Dr. Jallo. So how do you prevent metabolic complication related to diversion or neobladder? And is there a place for ileoconduit with radical cystectomy when the tumor cannot be resected? So great question. So there are things you can do pre-op and there are things you can do post-op. So preoperatively, personally, and I think most urologists would say this, the metabolic complications can be pretty significant. You tend to get more metabolic complications with especially with electrolytes, with a neobladder, and that's probably just because you have a much higher surface area of bowel mucosa that's interfacing with the urine. So there's a much higher reabsorption. The reabsorption complications you will often get are a metabolic acidosis. So it's a hypochloremic metabolic acidosis. To avoid those complications, I typically won't do a neobladder in patients with renal dysfunction. So you're only going to worsen the metabolic acidosis if someone, say, has a creatinine of 2 milligrams per deciliter or higher. So that's one way to prevent it. After the cystectomy, let's say someone had an ileal conduit and then develops an acidosis afterwards. You can give sodium bicarbonate. It's usually 650 milligrams or milliequivalents, 3 times a day. That will correct a metabolic acidosis. That acidosis is important because it can cause, it's associated with osteoporosis and bone leaching, etc. Some of the other metabolic complications include vitamin B12 deficiency. The ileum obviously is the most important part of your segment, your bowel, to absorb vitamin B12. If the patient develops a vitamin B12 deficiency, they will present with neurological symptoms, sometimes dizziness, sometimes fatigue. You can't just give oral vitamin B12 because they won't absorb it. It has to actually be injected. Hope that answers your question. Okay, question from Dr. Niang. What is the best time to do a cystectomy after neoadjuvant chemotherapy? Great question. I mentioned in the talk that the time from beginning treatment of neoadjuvant chemotherapy to cystectomy in our cohorts is usually around 9 to 10 weeks. The chemotherapy is typically given in 3 cycles at our institution with 2 weeks in between cycles. So cycle 1, 2 weeks later, cycle 2, 2 weeks later, cycle 3. That's a month of chemotherapy. We will typically give patients between 4 and 6 weeks after the end of chemotherapy before proceeding to cystectomy. And I think somewhere around 90% of our patients were treated in under 10 weeks. So I would typically go for between 4 and 6 weeks. That gives the patient enough time to recover all of their blood counts, et cetera. You don't want to do a cystectomy on someone who's going to be neutropenic and have, sepsis related complications after surgery. That also gives them a chance to get their nutritional status back up to par, et cetera. So I would typically say somewhere between 4 and 6 weeks. Next question was how to prevent bowel fistula. Great question. This is something we see typically rarely after cystectomy. There are a couple of possibilities where a patient may get a bowel fistula, though. So probably the most common one that I've experienced, and knock on wood, I haven't had one since I've been in attending. All these I saw when I was a resident, is with the bowel anastomosis. So there can be problems with bowel breakdown. What I tend to do during the operating room is, obviously we handle the bowel with great care. We use a stapled side-to-side anastomosis. I just try to palpate the lumen, the neo-lumen after our stapled anastomosis to make sure that it's nice and patent. I will often take the 2 limbs of the bowel and try to squeeze them both together to see if I can see any succus come up in between the staple line. That's always worked well for me. At the end of my procedure, I will also try and reach up into the upper abdomen and pull the omentum down, and I will typically tack it to the pubis. I think that probably helps you, prevent having any sort of cutaneous fistula, but it will not really prevent any sort of intra-abdominal, leakage. The other place you'll get a bowel fistula will be in the rectal area. So especially if patients have had prior pelvic surgery, say like a prostatectomy, or maybe they've had radiation for prostate cancer, that can be a very tricky place to operate. I think in all of the cases where I've done a cystectomy with in a patient who's had prior radiation, I've had a general surgeon along with me to try to peel the bladder and the prostate off of the rectum. I think in 2 of those instances out of maybe 5, my patient ended up getting had a bowel injury that was recognized during the surgery. And so the patient ended up having both an ostomy for the urine as well as an ostomy for the bowel. That one can be pretty tough to prevent. But I guess to answer your question, Dr. Niang, as I mentioned, I'm just really careful when I do the bowel anastomosis. I try to stress the anastomosis while while we're still in the abdomen. I try to pull down some momentum to prevent a cutaneous fistula. And then if I think I need it, I will have a general surgeon operate along with me. Dr. Tumafor, question, is there any further imaging to do after cystectomy to eliminate recurrence, or how does it present? So I guess it may depend on what you guys have available. We typically will do cross-sectional CT scans every 3 to 6 months of the abdomen. I like to do them with contrast, and I like to do a urogram. The rate of upper tract, local, I guess you'd call it, upper tract recurrence in patients who have a cystectomy is somewhere between 5 and 10%. So I will usually do a CT urogram when patients are following up. Some people will do CT chest at the same time. I tend to just get a chest X-ray. Lungs and lymph nodes are probably the most likely sites of recurrence. I don't think there's any imaging you can do to reduce recurrence, but you can certainly use imaging to detect it earlier. I mentioned, he asked, how does it present? Again, I think lungs and lymph nodes tend to be the most common sites of first recurrence. There's some data, if you look at patients with, say, a small solitary pulmonary nodule pre-op, and you look at sort of what is the outcome of those. Often those are just benign, inflammatory nodules. And we've actually looked at this at our own institution. If you look at like a 5 millimeter or less solitary pulmonary nodule that's present pre-chemo, and you look at what the clinical destination of all of those was, essentially in all cases, it was really just inflammatory. And even 2 or 3 years after cystectomy, those things didn't grow. If the nodule is somewhere between 5 and 10 millimeters, there's a higher likelihood that it will have grown after cystectomy. But again, the rate of those growing and becoming some kind of clinically meaningful recurrence is very low. Okay, another question from Dr. Jallo. How do you decide between ileal loop and neobladder? Do you always decide with the patient beforehand? So yes, my answer to that is it's really, I try to leave it up to the patient. So what I will often do is, what I'll always do is counsel the patient pre-op, at the time of their diagnosis, when they're coming back after their TURBT. I will start to talk to them about ileal loop, ileal conduit, and neobladder. The AUA has, the Urology Care Foundation, I think it is, which is part of the AUA, has some really nice literature. It's publicly available and free to download. Highly recommend you guys pull it up. There's information about bladder cancer treatment, surgical options, etc. Those are things you can print out and give to patients after you talk to them extensively about ileal loop and neobladder. I will just tell patients, and I'm very upfront with people about, loop versus neobladder. Obviously the neobladder has some upside because patients sort of have some semblance of being, quote, normal after their surgery, but there's also some downsides regarding the incontinence rates and nocturia and things like that. Okay, from Dr. Tamafor. Sorry, I didn't get the response to the question from Dr. Jallo about imaging prediction of MIBC. So I think, I'm not sure, are you guys asking about how to identify bladder cancer after chemo, but before cystectomy? Or is this after cystectomy?
Just asking whether imaging can consistently predict muscle invasive bladder cancer before surgery in such a way that you can track it more, insisting to track it with the pathology.
Okay, so you're talking about, I'm sorry, I misunderstood the question. I thought you were asking about how to follow patients after cystectomy, but I think the question is prior to cystectomy, can you identify? So the answer to that, I think, is there isn't an answer yet. There are institutions that are trying to use MR. I don't think CT will be very good for this. I think you need a little bit more soft tissue resolution than you can get with CT scan. With MR, there are some people that think that you can do, you can identify residual disease within the bladder and then tell whether it's muscle invasive or not. There's a couple prospective trials that I know of where patients are getting MR and then having a cystectomy, and then the PIs of these studies are going to correlate the MR findings with the cystectomy findings to determine if it's stage 2, stage 3, or complete response. I don't think the data is mature enough to really say one way or the other, though. Does that answer your question?
Yes, thank you.
Okay, great. Okay. Oh, we have big issues finding ileal loop pouch, often not available and expensive. Okay, great point. So I remember, so it's a good point. So having an ileal loop and needing to have the ostomy supplies, if you can't get them, is a problem. Obviously, if they can't put a pouch on their conduit, then they're not going to be able to collect, the patient won't be able to collect their urine and keep everything sort of clean. So neobladder is an option for those patients. Continent diversions, such as like an Indiana pouch or a right colon pouch, is also a possibility. But again, that requires a catheter, which may or may not be accessible. Those catheters can often be reused, and so that might be one option. Indiana pouch or right colostomy, right colon pouch also can be complicated because now you have a continent catheterizable stoma. Sometimes the stoma will leak. Sometimes the stoma will get strictured and the patient can't get a catheter into it. Those can be problems. One of the urinary diversions I've used, and I will admit I've only used this once, and it was on a patient who, this was when I was a resident, who was not only homeless, but didn't live in a city and actually lived kind of in a forest in the middle of the state where I lived in Missouri. And this patient had the exact same, concern that Dr. Jallo and maybe some of his patients are expressing. The diversion we used in this patient was what's called a Mainz 2 pouch, which was a very simple diversion. And essentially what happens is you perform a cystectomy, you leave the ureters, obviously, and you end up tunneling the ureters into the rectosigmoid, and you develop a rectosigmoid pouch. And the way you do that essentially is you make an incision longitudinally along the colon, and then as you close it, you close it in the opposite direction. So you open it long ways, and then you close it sort of almost like circumferentially in the same direction as you would if like you're closing it to be circumferential with the colon.
Are you referring to the main pouch?
Yeah, so you can plug the ureters in, and essentially what happens with that diversion is that the patient will pass urine and stool out of their rectum. So it is a continent diversion. There's obviously some chance, some risk of ascending urinary tract infections and pyelonephritis, et cetera. which is why when you do the ureterointestinal anastomosis, you will often you'll try to do them tunneled so that it's non-refluxing. That will reduce the risk of pyelonephritis. I've used that diversion, and I've said I would use it before if I ever had to do a cystectomy on someone who had grossly positive lymph nodes and I didn't expect would have a very long life expectancy afterwards. I would do that urinary diversion. I luckily haven't had to do it again yet. Dr. Jallo also asked about doing cystectomy in the, I think, was it in the absence of doing a loop in the absence of cystectomy? Did I read that right? So doing an ileal conduit when the tumor cannot be resected. Is there a place for ileal conduit with RC? I'm sorry, I don't quite understand the question, Dr. Jallo.
Yeah, like it happened to us often that we open for a cystectomy. We find that the tumor cannot be removed because it's adhering to everything. So
Yes.
and the patient has bilateral pyelonephrosis. Is there any place for ileal conduit for that?
Yes. So I think the question said with RC, but I think what you mean is with aborted RC. You're saying if you abort the cystectomy and just do a diversion, is that correct?
Yeah.
Okay, good. So definitely I've encountered those situations as well. Very tough for the patient. Obviously they weren't expecting to have that outcome when they went to sleep. We do often do a diversion absent of a cystectomy. So that does that opens up a couple of options. So one, often these patients have large tumors, they bleed. Patients have to come back to the hospital for catheters, clot evacuation, etc. These large tumors often also will obstruct the ureters and cause, patient needs to have a nephrostomy tube. Again, if you're in a low resource setting, nephrostomy tube changes may not be very feasible. So certainly diversion gets you out of some of that. Patients may still have hematuria, but often what will happen in the absence of urine is that hematuria isn't quite as bad, or maybe doesn't occur at all, because the urine has urokinase, which is obviously a clot buster. And so the urine itself is sort of an anticoagulant. And so the bladder will sometimes just clot off. That also opens you up to additional things such as radiation potentially, because you don't have to worry about stricturing the ureters, et cetera. Definitely I've encountered those situations, and yes, definitely we've done a conduit diversion without a cystectomy. I will also say anecdotally, those patients just in general tend to not do very poorly. So, I remember patients who died in the hospital after, being admitted for 2 or 3 months and never even got discharged. Those patients tend to be the ones that progress quickly and unfortunately just don't do well no matter what you do, whether you do an ileal loop or not.
Thank you.
Yeah.
I think we've gone beyond the time, which means that the topic is very important.
Yeah. Appreciate you guys paying attention and staying with me for this long. I'm going to stop. Did everybody get a screenshot that wants to get a screenshot? I'm going to go ahead and stop sharing here.
Yeah, you can stop. And we have Professor Nwofo to say the closing remarks.
Okay, go ahead.
It has been quite interesting. The topic has been so exciting, and I think we enjoyed it thoroughly. This is a very good expose on, what we knew before, but in a new dimension with all the new techniques.
Right.
We thank you so much for giving us this honor of sharing your experience with us, Phillip.
Okay, it's my pleasure. Thanks a lot, guys. I'm happy to help out anytime.
Yeah, and we thank everybody who has been on, especially McCommon, who is always, he is part of PAUSA now, so he's an honorary member of PAUSA. So we thank him for always joining us and also always coordinating most of these activities. and to our indefatigable secretary and everyone who is here. Well, I think we have actually learned a lot and we remain grateful. We'll hook onto the site and then, draw further from the richness of your selections. Thank you very much.
Cool. Thank you guys. I appreciate it.
Yeah.
All right.
Thank
Take care. Safe.
Thank you. Bye
Yeah,
bye.
Mohammed, thank you very much. Thank you very much for being consistent.
Thank you.
Thank you.
Thank you.
Take care.
Bye.
Thank you.
Okay.
Hello.